Welcome to the Just Ingredients podcast. I'm Cara Lynn, and here we talk all things nourishing to the mind, body, and soul. This is a place where you can find just good ingredients to life. Dr. Mary Pardee is a naturopathic medical doctor and a certified functional medicine doctor who specializes in integrative approaches to gut health and longevity in Los Angeles, California. She is the founder of Modern Med, a medical practice that provides medical and health services to patients via in-person consults as well as telemedicine. For those who cannot work one-on-one with a Modern Med practitioner, Dr. Mary also created a gut health course that dives into the most common gut-related complaints and natural solutions to start healing. Welcome back to the show, everyone. Today's guest, Dr. Mary Pardee, is a wealth of knowledge, and I'm really excited to talk to her because in all 150 episodes or so, I have never had a guest come on and talk about blood work and what tests you should take and what tests are for what things. And I have so many of you that ask on a daily basis about blood work and different tests. And so I am so excited to bring a doctor on to answer all of these questions for you guys. So thank you so much, Dr. Pardee, for being here.
Thank you for having me, Carlin. I'm really excited. This is one of my favorite things to talk about too. I love getting geeky with the blood work, so we can go into it.
Oh, good. Well, before we get into the blood work, will you just tell my listeners a little bit about yourself, your background, and why you got involved in the medical world?
Yeah, so I am a naturopathic medical doctor. My background is in research, so I went into research right after I graduated pre-med. And I was in physiology research for the government, looking at performance-enhancing effects for warfighters. So I was working for the Army on the East Coast for a little while. And that was really the trajectory I was heading down, where I wanted to go into research. And I loved science and data and collecting and figuring problems out. And at one point I realized, especially working in the government, there's so much red tape and you can only get so far doing some things. And I realized that there was a gap between what we were learning in the labs and then what was being implemented out in the real world. And I don't think I had enough patience for that lag that was there. And so I really wanted to figure out a way to shorten that gap. So on average, it can take about 17 years for some of the research to actually hit clinical practice and be implemented in a doctor's office. It's a really long time from the time that we start to figure something out to the time we actually start to implement it. And if you know me personally, I don't have patience is definitely not my virtue. And so I was like, I need to get this implemented much faster. And so then I decided to go to the clinical route. And at that time, I was really into learning about herbs and lifestyle and how our lifestyle actually affects our health. And so the naturopathic medical route made a lot of sense to me. And at this point, I help people making sure that they're not just not sick, but they're also actually healthy. And with my patients, I'm looking out for years and years to come, saying, okay, you're healthy right now. How can we make sure you're healthy in 20, 30, 40 years as well? And lab work has a big piece to do with that, as well as the imaging studies and other advanced technologies that we have right now. And I love talking to people about them.
Well, like I said, I'm really excited to have you on the show today because I have so many listeners that are just sort of confused, about blood work and things like that. So before we delve into the different types of blood work or tests, let's just start at the beginning, the basics of why is blood work important? Why should everybody know what's going on in them?
Absolutely. Yeah. So blood work is one of the ways that we have a little window into the actual body to see what's going on in there. It's able to tell us things that are a little bit more nuanced in the body as well. Obviously, we can have symptoms that are external, like rashes or hair falling out or fatigue, things that are much more visible and tangible to us. But there's also a lot of things going on inside the body that don't have symptoms. So you'll see heart disease is the number one killer in the United States for both men and women still. And we call it a silent disease for a reason, where a lot of times people will have heart disease that is in progress, but won't have any symptoms at all. And this is where we need to rely on some more nuanced testing options like blood work, like blood pressure, to be able to detect diseases before they become symptomatic. Because for things like heart disease, We don't want a heart attack to be the first symptom of cardiovascular disease. And so we use blood work as a way to say what's going on at a biochemical level and what do we know about those measurements, and then what can we do to actually change them. And so when I look at somebody's labs, I require them to come back for an actual lab review, which not all doctors do because our system isn't built for longer visits, really. But we sit down with their lab work and I go line by line with them saying, okay, this is what this means. And here's your range, which is normal, but I'd actually like it to be a little bit lower or a little bit higher because of this reason. And I'll usually pull out some research studies and we'll talk about why it's important to get it into that optimal range for them. We can talk about those today.
I wish everyone had a doctor like you, because there's not very many doctors that sit down with the actual results and say, okay, let's look this over together. So that would be amazing. So blood work, I feel like, is this Egyptian code for a lot of people. They look at their test results and are like, I have to decipher this somehow. Like, I have no idea what's going on here. So let's talk about some basic blood work tests that probably insurance covers, that are just the basics that people should go get. So for instance, I know about the comprehensive metabolic panel. Is that one you recommend everybody get?
Yes, absolutely. So comprehensive metabolic panel, or CMP, is very standard. Most doctors will run that, or something called a BMP, which is a little bit more basic. But one of these two, your doctors will run on your yearly blood work, and it's going to tell you your fasting blood sugar as long as you were fasted for the actual blood draw. And that can be helpful for some people. It's not as detailed of a measurement as some of our other metabolic tests that we have, which we can talk about, but it's a good kind of baseline one where if you come back and your fasting blood sugar is 150, then that tells us a lot. If it's within the normal range, it doesn't tell us a ton at that point. And then you have something called creatinine. So creatinine is one of the measures that we look at for kidney function in the body. And this is an example of one that can be helpful if it's in normal ranges. However, if you come in and I just saw Tom Brady on TV, but if you're a big football player, right? So maybe like Mark Gronkowski, if you're a big muscular person, even you don't even have to be that big, your creatinine could be elevated because of just how much muscle mass you have on your body, which could then indicate a lower kidney function measurement, but it's not a true measurement of low kidney function. It's just affected by your muscle mass. And so this is where it's really important as a clinician to be able to evaluate and say, oh, we should run something additional for this person called cystatin C, so that we get a more accurate measurement of their actual kidney function, because they have much more muscle than the average person. And so that's kind of how I'll start to read labs and say, oh, your creatinine's a little bit higher than I'd like to see it, but you have a ton of muscle, so that's why it's happening. Let's run cystatin C and get a true measurement of your actual kidney function. And in that CMP, you'll also get your electrolytes, which are really important, and you get your liver function tests, ALT and AST. And right now in America, we have an epidemic that's happening of metabolic dysfunction and metabolic syndrome. And so we're really looking at those ALT and AST numbers for liver function, because there's a lot of people that have something called fatty liver, where you'll see mildly elevated liver enzymes. And we want to look into that, make sure it is fatty liver, and then make sure we can treat it, because that's something that can be definitely treated with diet, exercise, lifestyle.
Okay, so interesting. So I have a couple questions then for you. The fatty liver, I just read an article the other day that it might, if we keep going at this same pace, it could become the number one killer in America rather than heart disease. And so fatty liver, is this purely from things like our diet and alcohol and stress, or is it other things that are contributing to this as well?
Yeah, great question. And it's definitely on the rise. We see it all the time in practice. And it is treatable. So I want to empower people with that. It's not a non-reversible condition unless you've got to the point of cirrhosis of the liver. Once you're at cirrhosis of the liver, that means destruction of the actual liver tissues. But there's a lot of time before that it can be treated and caught. And so with fatty liver, you have a couple of types of fatty liver. One of them is called NAFLD, which is non-alcoholic fatty liver disease. And that's where we see it as a byproduct of lifestyle. So it's usually can be treated with a reduction in body weight. So What happens is when somebody starts to gain weight, that fat has to go somewhere, right? And one of the places it ends up going is going to be the liver as well. And so it's a symptom of metabolic syndrome. We want to look at insulin sensitivity in those people, but weight loss is going to be a huge part of the treatment process in fatty liver disease. We have, we can go into this too when we're talking about DEXAs, but you also can have people who are normal body weight, but they still have obesity. And I know people are going to hear that and say, what do you mean by that? But we call it normal weight obesity, where somebody is a normal BMI. So their BMI is normal. However, they have excess body fat. Another kind of slang term for it is skinny fat, which you may have heard. And so we are seeing some people who are not technically overweight from a BMI standpoint, but they have this kind of skinny fat or normal weight obesity going on, in which case we're optimizing for body composition in those individuals, reduction in body fat, increase in lean body mass to optimize metabolic markers that way. But majority of people, weight loss is going to be key. You also have alcoholic fatty liver, which from its name, you can kind of tell it has to do with drinking alcohol. And so for that, it's going to be reduction of alcohol intake to help the liver cells function.
Okay, so that the liver testing will be taken care of in the comprehensive metabolic panel, correct?
Correct.
Okay, so then when you're talking about the fasting blood sugar, is this talking about your A1C or something different than the A1C?
So in your CMP, the comprehensive metabolic panel, you're just going to get glucose as a measurement. So it's just your fasting blood sugar if you're fasted for the study. If you want to look at A1C, your doctor has to order that separately. And I do suggest it's one of the tests that we run on all of our patients. Hemoglobin A1C, that's going to be your average blood sugar over the last 3 months, which gives us way more data in my mind than just a single fasting blood sugar. Because your blood sugar is reactive, and it should be. We want it to be, meaning that if you're fasting, it's going to be lower. And then as soon as you eat something, it's going to go up. And, your blood sugar is going to go up and down all day long, depending on what you're doing. Your A1C is a much more stable marker because it's measuring, okay, what happened over the last 90 days for you and giving that report, which is really useful. And that's really a more useful tool to look at prediabetes and diabetes as well for a lot of people. One step further, which is going to be a little bit harder, to get covered by insurance, but not impossible. We do it with our patients, is a fasting insulin measurement. So your fasting insulin is going to look at the hormone insulin, which insulin is like the gatekeeper for sugars in the cells. So when you eat something that has sugar in it, your body puts out insulin. The insulin allows that sugar to get inside the cell. And early signs of insulin resistance, you'll see increases in that insulin level because it's taking more and more insulin to let that same amount of sugar into the cell. So the cell is literally becoming resistant to its actions. And that can be an even earlier indicator of some sort of mild insulin resistance or like at the verge of prediabetes, even before your A1C starts to elevate. Because we're all about prevention in my practice and me personally, like we want to know the earliest sign versus waiting until it gets to the point of even prediabetes.
So I'm curious because I know insulin resistance is on the rise. And so are you seeing these A1C numbers just climbing in society?
Yeah. You're seeing A1C levels increasing. You're definitely seeing fasting insulin levels increasing first. So you'll see that as a marker that'll go up before your A1C. But it's definitely becoming more and more common. And I will say the clientele that ends up seeing me is typically a healthier clientele. I've worked in different populations before, but we really want to get those people in who need it the most. And we want to be able to look at to see, okay, is that A1C starting to climb? Is it going to 5.5, 5.6, and 5.7? We want to intervene as soon as you possibly can, because the sooner you do it, the easier it is to treat it versus waiting for full-blown diabetes to develop.
Just like the liver, this A1C is definitely controllable by diet and lifestyle factors, correct?
Yeah. A1C is another one where we really want to look at what is the person eating, how much are they eating. So we're looking at calories. We're looking at macronutrients to some degree as well. We're definitely looking at saturated fat in the diet. We're looking at fiber in the diet. And we're definitely looking at exercise and lifestyle. So are you sitting at a desk all day long? Is there a way that we can get you moving just throughout the day? We have this thing in our body that's like a miracle when it comes to metabolism, and it's called muscle. And if we can get those muscles actually moving, your muscle is one of the few ways that we can get sugar into the cells without the use of insulin. So it's an insulin independent action when you have your skeletal muscle working. And so it's as simple as, can we get people going outside for breaks and going for a walk or doing their meetings on the phone, walking around the building. But there's so many things with lifestyle that we can do. We also have pharmaceuticals if we need to help get the person into the place they need to be.
Okay, so I'm curious. We talked about the comprehensive metabolic panel and the insulin and hemoglobin A1C. Most likely those are covered by insurance. Are there other ones that are commonly covered by insurance that people should get?
Yeah, and your insulin may not be covered by your insurance. We can get it usually covered for our patients. It's going to be doctor dependent whether they feel comfortable ordering it or not, depending on your family history and where you are at personally. You'll always get a CBC, a complete blood count, covered by insurance on your yearly exam as well. That one's going to look at your red blood cells, your white blood cell count, hemoglobin, hematocrit level, and it looks at a few other markers in terms of how big your red blood cells are and that type of thing. It can indicate if you have an anemia present, that's where we would see it, is in that CBC. And also can indicate something's going on with iron or B12 or folate, depending on the results of that test. And so that one's going to be one that's almost always included in the standard blood panel. And then your lipid profile is typically included in your yearly as well.
Okay, let me ask you about that CBC, the complete blood count. So I'm curious, how does that, because I know it can show anemia, things like that, but I'm curious how it could show you about B12 or folate.
Yeah. So, and this is the fun thing in my mind about blood work is it tells you the obvious thing, but then the more you know about the markers, the more you can start to pull out for them. So we have one marker that's called MCV, which is mean corpuscular volume. And what that's telling us is how large are your red blood cells. And the size of the red blood cells can tell us something potentially and requires further, investigation. But for instance, if somebody comes in to see me and their red blood cells are very large, so they're outside of the normal range, which, say they're around like 101 or something for the MCV value. The next thing that I would want to go and look at is what are their B12 and folate levels? And I run those for my patients, so I would just have those offhand. If you didn't run them, you could do a follow-up blood test to actually look at them, because if you are deficient in B12 or folate, it can cause your red blood cells to be larger. So it's a symptom that you can see. On the flip side, if you have really small red blood cells, which we call microcytic, then it can be a symptom of iron deficiency. So we'd want to look then, I'd kind of scroll down the panel and I'd say, what's her ferritin level or what's her iron, serum iron level? And sometimes you will find that those are all normal, and this could just be the person. So sometimes people just have larger red blood cells, but you would know by looking at all of those things. But a lot of the times it's going to be indicative of either iron deficiency or B12 or folate deficiency. And then we would proceed and go from there.
So interesting. So about B12 and folate, can you measure those with blood work? And is that a common one for doctors to test all your vitamins or no?
It's not common, so it's not included in like a very standard yearly panel. There's a lot of doctors that would be open to measuring those too. So those aren't two that are, crazy to ask for because of this right here, especially if you're vegetarian or vegan. So B12, is really much more concentrated in animal sources. So if you are vegetarian or vegan, you could tell that to your doctor and they'd be more inclined to run something like that. But you can definitely order them, and we almost always get it covered for our patients depending on their insurance plan. So sometimes you just have to be an advocate to your health, to why you want something and that you want to look a little bit deeper. And then if you have the financial means and you're working with a doctor who is taking your PPO insurance plan, you can always say, hey, I'm actually totally fine paying out of pocket if insurance doesn't cover it. Will you just order it for me and I'll handle the bill? Because sometimes doctors just don't want to order because they don't want you to be angry if there is a bill afterwards.
It amazes me because I talk a lot about mental health and depression, anxiety, and folate and B12 play such a huge role in those. And depression is just skyrocketing, and people will go to the doctor for help and they won't even test the B12 and folate. So I am amazed that it's not just part of the standard testing that we do here in America.
Yeah, we definitely have some work to do when we're looking at what should be the standard of care in my mind. And I understand part of it when you look at all the different sectors of it, like how our insurance system works and how the doctors work. We have a lot of work to do on all of the different sides to get to where we really should be. But yeah, it's frustrating to be the patient on that side too.
Okay, so I want to ask about another test. So you mentioned the iron and the ferritin. And so is this a common one that's always tested? And what concerns do you see with this? Do you see women low on iron? Is that a common thing or not necessarily?
Yeah, great question. These are more common tests. It depends on if you're premenopausal as a woman or postmenopausal, because iron deficiency is obviously much more common premenopausally when women are cycling. And it's a really important one to run because it's very, very common for women to have below optimal ferritin levels. And so the American Association of Hematology came out and said that really women's ferritin level should be around a 45 or above. And the amount of women that I see that are far below that is pretty significant. So it's one that I'm measuring on everybody, especially if you have even men, we're looking at it more so if they're having any GI issues, we want to make sure that ferritin's not low, which could indicate some bleeding in the GI tract. Or on the flip side, when ferritin is very high, it can indicate either acute phase reactant, meaning it's working as an inflammatory marker almost in the body, or you can have something called iron overload from a genetic condition, for instance, like hemochromatosis or some other things. But I think it's an important one to run on occasion and potentially more frequently if somebody has heavy menstrual cycles and is, constantly dealing with some iron deficiency. We want to keep an eye on that to get their levels up.
Okay, good to know. Let's talk about the thyroid panel, though, because I have a lot of listeners who have thyroid issues, whether it's Hashimoto's or something else. And I hear this one to be confusing out there because so many doctors will say, oh, you need like all 5 of the parts of the thyroid panel run, but in the ones that insurance covers for a lot of people, it's only testing one thing. And so explain this thyroid panel to us and what we really need tested.
Yes, yeah. So doctors will run TSH very commonly, which is thyroid stimulating hormone. That's actually the hormone that comes from the brain and then goes and tells the thyroid to produce your thyroid hormones, which are going to be T3 and T4. And so I will usually measure TSH, but also free T3, free T4, and then the antibodies, antithyroid globulin and anti-TPO antibodies for somebody at least the first time that I see them, just to get like an overview of what is going on. Some people will also run reverse T3. That's another marker that is common in more of the functional medicine world. And that one depends for me on whether I'm going to run it or not. But it's not uncommon to see somebody with a normal TSH, but let's say a low T3 or low T4, or normal TSH, but elevated thyroglobulin antibodies. And so when we look at the whole gamut of the thyroid and the thyroid labs, it gives us a little bit more information than just one single measurement. If everything is normal, I'm not going to run that complete panel on the same person every single time. So it will, once in a while we may run it again, but it's not something that needs to be closely tracked if everything is in good measurement. But we want to at least start to assess, especially if somebody's dealing with fatigue or hair loss, just like, do we know where everything stands right now? And then what is that telling us and where do we want to go from there? But those markers, some endocrinologists will run the free T3, free T4 for sure. And then others, you may have to kind of advocate a little bit more just to get the full thyroid panel at least once.
It's true that people will go into doctors and say, like, I'm losing my hair, or can't lose my weight, or I have no energy, things like that. And their TSH is in the normal range. But then if they went and did further testing, something else on the thyroid might be off, correct?
Yeah, potentially. Potentially it could be off. You could have elevated antibodies to those thyroid markers, which can indicate something called Hashimoto's. And depending on where you're at in the spectrum, we may want to give some supportive therapy for that. And then, just the other week, I have athletes that I see all the time in practice, and their TSH can sometimes creep up. So, it's not uncommon for some of my professional runners to come in and their TSH is like 5 or something. And I'm just like, think you might be overtraining. Like, can you take a break? Can you take a few days off? And so it also can help us just guide what we're doing in life too. Are we overstressed? Are we underslept? Are we overtraining, or what's going on? And using those to actually make lifestyle decisions and listen to our body with a more fine-tuned lens can be really, really helpful.
So, do you have any suggestions though for women? Because I have a lot of frustrated women with their thyroid, meaning they will hear all the time, like, your thyroid's fine. And then they'll find out years later it's not. And so, what advice do you give to women when going and getting a blood panel done for thyroid?
Yeah, I would go in with a wish list. So I would write down the tests, maybe you're taking notes today and write down the tests that you want to get and the reasons why you want to do them and talk to your doctor about them. And if you are okay paying out of pocket, if insurance won't cover them, then voice that as well. And just be an advocate for your own health. And then, there is the option too of searching for another doctor. And, I think if somebody's really not listening to you, and, even especially if you're like, hey, I don't mind paying for it out of pocket, and they still don't want it, they're being like a gatekeeper, then I would really consider working with somebody who is more willing to work with you on your health journey, which I think is really important. Sometimes it can be hard to find those people, but they do exist. And, just keep kind of talking to doctors and hopefully you can find the one. It's like finding a therapist, right? Like you talk to a few before you find the one that you jive with.
Okay, so will you just tell for the listeners the names of the thyroid tests that they should write down in their notes to take to their doctor?
Absolutely. So it's TSH, free T3, free T4, anti-thyroglobulin antibody, and anti-TPO antibody. Reverse T3 is the other one. It's one that I don't even run for all my patients. But if you really think that something's going on with your thyroid, then you may want to do that one as well.
Okay, thank you for saying those because, like you said, most doctors run just the TSH, and so that's good that they have all of those names now. So, back to vitamins. I forgot to ask you this when we were talking about B12 and folate. Vitamin D is a really important one to test for, but that is one that insurance covers, correct? And why do they cover that one, but not some of the other ones?
Yeah, your insurance should cover a vitamin D level. We don't have any issues in our practice getting it covered. What's funny is some doctors still don't run that one. So there was a statement made by the US, I think it's USPT, I forget. So it's a task force that makes statements about health, and they said that it may or may not be worth it, and we don't think that the benefit is greater than the risk in people who don't have symptoms and aren't pregnant, kind of thing. Which I find funny because we also know that if you live in a higher latitude and you're prone to vitamin D deficiency, it increases your risk of cancer of the colon, prostate, breast, ovary, esophagus, and several other tissues. Not to mention increased risk for osteoporosis. And, in children that are exposed to the most sunlight, they have a 40% reduced risk of non-Hodgkin's lymphoma. And so for us to say, we don't know if it's actually helpful or not, feels really, really silly. So it's definitely one that I want to check on people. And you want to think about vitamin D in terms of when you're testing it. So vitamin D levels will be highest around the September because you've had a full summer of exposure, at least in the northern hemisphere, but you'll have a full summer of exposure, and you're going to see levels at their lowest point, closer to like January, February. And so the time of year you're testing it is also going to tell you something as well. But we really want to get vitamin D levels between like a 40 and 70 sweet spot to reduce the risk for those diseases as well as others. And it's an easy one to test.
That is crazy to me about not testing when it contribute to cancer, but it also can play a huge role in depression and energy. And we've got so many people that just don't have the energy that they wish they had, and so many people with depression. And so that is one you would recommend, right? That all people have done?
Yeah, absolutely. I don't see a reason not to test your vitamin D. If you're in the optimal range, that 40 and 70, then you don't have to do anything. If you're not, then it's an easy supplementation to get you to that range.
Let's take a quick break to hear from our show sponsor. Switching to a more toxin-free lifestyle is a challenge, and some swaps are harder than others. One of the swaps that has been hard for me is finding a laundry detergent that cleans my clothes and leaves them smelling good. Thanks to my loyal listeners and followers, I learned about Truly Free. Truly Free creates both laundry and home cleaning products for families who want family-safe, non-toxic cleaning solutions that actually work. Truly Free is free from chlorine bleach, phosphates, 4-dioxane, and harmful fragrances. I am getting the results I want without any of the dangerous chemicals. Truly Free offers refillable and reusable packaging, which empowers families to reduce their environmental footprint. Get real cleaning power with absolutely zero scary ingredients. Use code JUSTINGREDIENTS at trulyfreehome.com today. Now back to the show. Let's actually talk about supplementation with vitamin D really quick, because you hear a lot of things about vitamin D. And so we want to supplement with a D3, right? With a vitamin K, or do you think differently?
Yeah. So we give D3. There's good research that D3 is probably superior than D2, your uracalciferol, at protecting against a lot of these diseases it's associated with, like hip fracture from osteoporosis and osteopenia. And a lot of times we'll pair it with a K2. And I haven't actually delved into that research as much. What we talk about in the integrative space is that vitamin D3 should help you absorb the calcium from the intestines, which is definitely true. And then K2 helps to make sure it goes into the bone to protect our bones. And so I don't see any hurt by adding K2 in, which is why ours is paired with it.
Okay. Well, let's move on to another test, because I know another test that I've actually been hearing a little bit about on social media is the homocysteine test. But what in the world is that actually testing, and why do we need to know what our homocysteine levels are?
Yeah, this one's a little bit harder to stay at like an elementary level when we talk about it, because it's a complex process that goes on in the body. So you have a methylation cycle in your body, and methylation is literally just transferring one carbon unit from one thing to another, and it helps to turn on, turn off processes throughout the entire body. But homocysteine is one of the things that is involved in that methylation cycle. So methionine becomes homocysteine through this carbon transfer. And when we have the buildup of homocysteine, when homocysteine levels get higher and higher, it's signaling to us that there may be a deficiency of some of the cofactors that are involved in that methylation cycle. Because if we had enough of all of the vitamins and cofactors in that cycle, then it would keep homocysteine at a normal level. It wouldn't cause a buildup to arise. And so homocysteine, there's been a few studies, and I think there needs to be more, but what we see at the current moment is that homocysteine, when it's elevated, can be associated, and that word is really important, associated with a twofold increase of coronary artery calcification progression. And I pointed out the association because we don't know if it's causation yet. Is this kind of just a bystander, or is this involved in the actual cause that's there? So we need more information about that one. There's been a couple other studies. One of them was the China stroke primary prevention trial, and they used folic acid treatment in high homocysteine individuals, and they found a 73% reduction in strokes, whereas there was no reduction with the low risk group that had a normal homocysteine level. And so we say, okay, maybe reducing homocysteine levels to an optimal range can reduce the risk of stroke in individuals who haven't had a stroke in the past. And then there's one other study that's looking at something a little bit different outside of cardiovascular disease. It's the VitaCog study. And this VitaCog study was done by Smith's group, who's done a lot of the studies around homocysteine. But it was a randomized controlled trial. And what they looked at is the rate of brain atrophy in individuals with a baseline level of homocysteine above a 13. And so all of these people in the study had mild cognitive impairment. So they were already having effects of the brain when they were enrolled in this study. But they found that when they supplemented people with these B vitamins that had a high homocysteine to start, there was a 53% lower rate of brain atrophy in those participants. And so we're thinking that potentially supplementing with B vitamins, the cofactors of that methylation cycle, may reduce brain atrophy in people with mild cognitive impairment. And so there's enough research in my mind to test homocysteine, number one, and if it's elevated, to get it below, optimal ranges. So I like my patients to have a homocysteine at 9.5 or below to reduce their potential risk. And again, this is one that I think we still need more information on, but as of right now, I see more benefit than harm from doing that.
Okay, so I'm curious, if homocysteine levels are high, do methylated B vitamins help bring that down, or could they?
Yeah, exactly. So that's what the studies we're looking at is B complexes, B vitamins. The Bs specifically that are looking at that cycle as cofactors are going to be B12, B6, B9, which is folate. Also, trimethylglycine can be a cofactor in that as well. And sometimes there's a few other things too, but those are going to be your main drivers right there, are the B vitamins and trimethylglycine.
This is sort of off topic, but those with the MTHFR variant, could they possibly see higher levels of homocysteine because of that maybe difficulty of methylating?
Yeah, exactly. So, and that's also why I really like running homocysteine, even more so than looking at the actual gene itself, because I want to see, is this functionally showing up in the person versus do they have the gene that codes for an issue to arise? So is that actually affecting the person or not? And so, yes, the answer is yes, you can see that.
Oh, I love that, though, that you're testing the homocysteine rather than the gene, because I do know, like, if you have double of that variant, it's going to maybe play more of effect than just one variant. And so that's actually a really great way to look at it. Also, though, does a higher homocysteine level imply at all that your liver needs some support or may need some support?
Yeah, I actually haven't heard that, but it could be something that I just don't know yet.
Okay, so we've talked about a lot of tests, but am I missing any of the important tests that you think we need to always have done, or the common ones that insurance covers?
We covered most of the basics around insurance. We didn't talk about a lipid panel, though, I don't think. That's going to be one that insurance will cover. It's extremely important. Definitely do it.
You know what? We forgot lipid. So let's talk about lipid and why that's important besides just the cholesterol levels. Let's talk about why that's important. But also we forgot to talk about inflammation and how we test for that. So let's do both.
Okay, great. So with your lipid panel, the standard one that will come on your yearly is going to be your total cholesterol. It's also going to tell you your LDL-C, your LDL cholesterol level, your HDL-C, and your triglycerides will show up on there as well. And the numbers that I'm really looking at are going to be more so the triglycerides and the LDL-C. So your triglycerides are going to tell you about insulin sensitivity and your metabolism in that way. So when triglycerides are elevated, and I really like to see triglycerides less than 100 ideally, but if triglycerides are getting above 150 especially, then we're showing potential signs of insulin resistance that could be going on in the body. And so you'll see elevated triglycerides in people that are overweight or obese, oftentimes pre-diabetic or diabetic, or in earlier signs of insulin sensitivity. So you may say, I've never been diagnosed with prediabetes, But I am noticing I'm carrying some extra weight. And so that's where we want to look at diet, reducing caloric intake if there is excess fat that needs to be shed, and potentially reducing carbohydrates a little bit in the diet. And again, it's very individualized. So talk to your doctor about what they think that would be appropriate for you. And then you have your LDL-C level. So your LDL-C level, this one is very controversial in social media, at least. I posted about it and I saw that firsthand. And I understand. So I come from a place of exploration personally, where I've tried every single diet out there. I went on keto, Atkins, and paleo, and vegan, and vegetarian. Like, I've tried them all. And when I was actually working in research for the government, I had access to actually test like real time, like all of my things. So I'd go keto and then I'd test. My LDL-C went up crazy high when I was on a ketogenic diet. And I also have a genetic component personally myself. But I went through a period of being like, does it actually matter? Because there's a lot of people out there saying LDL-C doesn't matter. It doesn't matter if you're insulin sensitive and, otherwise healthy. And from all the research I've done, it does matter. And it most often correlates with another marker called apolipoprotein B, or ApoB for short. ApoB is not one that's going to be a standard on your yearly blood work. A lot of doctors are now okay with running it if you ask nicely, especially if you have a family history of heart disease. You can tell them that as well. But when ApoB and LDL-C correlate, meaning the person has a high LDL-C and a high ApoB, we really know that that is an increased risk for atherosclerosis, or ASCVD, meaning plaque formation in the arterial walls. There are some people, and I've had just a couple over years and years, where LDL-C will be high, but ApoB is actually low. And in that person, we more often will track the ApoB in them. So there's like a few people who are a little bit different. Most of the time, like majority of the time, those numbers are going to track together. You're going to have a high ApoB and a high LDL-C. We really want to get those into an optimal range to reduce the risk for atherosclerosis, especially given how prevalent heart disease is and that it's silent. So people will say, but I feel great. I feel healthy. I'm not doing anything. Like, I feel really good. I don't need to do anything. Majority of people with heart disease don't feel anything. And, what we don't want is the first symptom to be a heart attack or stroke.
So good to know. Okay, so tell me though, are there ranges that the LDL and HDL should be in, or not necessarily?
Yeah, HDL is way more complicated, and I'm still learning a ton about HDL. We used to just say we want HDL to be high. It's a signal of health. And we know that that's not true. Now there's kind of sweet spots to it. And so lab ranges for HDL, I believe, are greater than 40 for men, greater than 50 for women. But you can get to a range that may be too high and indicating that something is also wrong. So there's a little bit more nuance there that we probably need like an hour and a half to just go into that one specifically. For LDL-C, we know it's much more cut and dry, where we want it optimally less than 70. And then normal is less than 100. And so for everybody that's seeing me, they're seeing me because they want to really prevent and be more aggressive. So we're getting it less than 70, ideally.
And what you said about triglycerides is interesting to me, about the insulin levels and insulin resistance. And so if you have high triglycerides, I'm assuming your A1C is high? Do they correlate?
Eventually, they will likely correlate, but at the time of the test, they may or may not. So you could see triglycerides elevate before the A1C will elevate. So you can have somebody that comes in and their triglycerides are 150 and their A1C is still at 5.5. If they do absolutely nothing, there's a good chance that A1C will start to go up and up and up. And so that's where just using a finer comb to sift through this data and take it and actually take action on it can be really helpful, because you can prevent that A1C from ever getting to a out of range place.
And so back to that A1C really quick. That A1C is when when it's out of a bad range. Is that due to our blood sugar levels looking like a roller coaster basically every day, with the huge spikes and the crashes, rather than trying to keep that blood glucose level balanced throughout the day?
Yeah, so your A1C is it's almost like a little calculator for your body in that it gives you an average of what happened over the last 90 days. So, yes, could it be very high highs and low lows and just kind of like up and down where your average is still elevated? Absolutely. It could also be somebody that has something called hepatic insulin resistance, where they may not be going super high and super low, but they're just kind of elevated all the time. And so their average is still higher over the course of the 90 days. So we're not able to tell what's happening on a day to day with A1C. We're just able to say, on average, your blood sugar has been about this amount over the last 90 days. Every A1C correlates with an average blood sugar amount.
Okay, so now back to those triglycerides. Why is it, though, that the triglycerides give us a little insight into people's blood sugar levels and insulin resistance and stuff? How do they correlate?
Yeah, sure. So triglycerides are going to be little kind of fatty acids that are circulating around. And when we have excess caloric intake that's coming in, you're going to get excess accumulation of these triglycerides that have to be shuttled around the body. So it's an indicator of that. And then we can also see that when somebody has insulin resistance present, it tends to increase the triglyceride levels that are circulating as well. And so treating that insulin resistance and, if there is weight loss needed, then reducing body weight as well will both be beneficial to lowering those.
So let's move on to inflammation because that is very trendy on social media. As you know, we talk about inflammation all the time. And is that something that can be tested in blood work?
Yeah, this is actually one of my favorite things because I think we throw around the word inflammation a little too loosely sometimes, where it's like, okay, this causes inflammation, this causes inflammation. If you think something causes inflammation, then go get your CRP. Well, that's one of them. So HSCRP or SED rate is another one. CRP is a little bit more stable, but SED rate is the other one. Those are inflammatory markers. So for instance, somebody has something called inflammatory bowel disease, like ulcerative colitis or Crohn's disease. It is very common for a CRP level to be elevated. And that indicates that there is inflammation going on. If somebody says, hey, that eggplant that you're eating is inflammatory, well, eat some eggplant, test your CRP. And if it's not elevated, I don't know how we're saying that it's actually inflammatory for you. It feels like a little bit of I don't know if I would call it a scapegoat or what, but definitely very loose use of the word. So CRP is one that a lot of doctors will run on a standard lab panel, and is one that insurance will usually cover as well. And an elevated level can show an increased risk for cardiovascular disease because of low level inflammation that can be going on. But we can see that in the blood.
Inflammation, I mean, that can be the root cause to a lot of different things like joint pain, low energy, depression, anxiety, correct? And so I feel like everybody should know what their inflammation levels are at.
Yeah, it's one that we run on absolutely everybody. But you will have people that will have low energy and they will have joint pain and their CRP will be less than 0.3. So there's not an inflammatory process going on. It's something else. But if you have, for instance, arthritis, rheumatoid arthritis, your SED rate and your CRP could be mildly elevated, indicating that there is an inflammatory process that's going on that's contributing to that joint pain. So just test, and then and then you can go from there.
Yeah, test, don't guess, just test and at least rule that out and start looking for the other reasons. Okay, so what other tests have we missed that you love to run on patients or think that people should have?
The other marker that I run for cardiovascular disease it's called LP little a. Lipoprotein A, but little a, is a very much genetically linked marker. So it really has to do with your genetics, but an increased level increases the risk for atherosclerosis and heart disease. And so it's another indicator for us. When I see somebody have an LP little a that's elevated, I really want to make sure we're extra vigilant about getting their ApoB and LDL-C well below optimal ranges to reduce their risk and make sure that they're not smoking, that their blood pressure is in range. So we'll go through the whole cardiovascular risk reduction kind of format for them to make sure that we're doing everything else. We don't currently have a great tool to lower LP little a. There's a medication class that came out recently called PCSK9 inhibitors, and some of those do lower LP little a, but it's still up in the air as to whether that reduction in LP little a correlates to a reduction in risk for heart disease. But that's one to just know where you stand so that you can change all the other things that we do know for sure reduce the risk for heart disease. I run testosterone levels on pretty much everybody, free testosterone and total testosterone. We want to make sure that those are in good range, especially if people are complaining of low libido or drive or, for men, any issues with sexual function.
So talking about testosterone, do you also test progesterone and estrogen too, or not necessarily?
It depends. So those ones, it depends. If a woman is symptomatic or she's unable to get pregnant, then we will there. The interesting thing about estrogen and progesterone is it is very variable throughout the cycle, right? So if it's a premenopausal woman, you want to make sure you're testing at the right times. And so if there is something that is going on with a woman, then we'll test those levels at the correct time to catch it. But what I see a lot of in my practice is PMS. So women will come in with, I'm just really, really anxious or emotional, like more so than I think I can deal with kind of thing. It's affecting my relationships. It's affecting my quality of life. And those women, as long as it's not contraindicated, will actually just use progesterone in the luteal phase, because there's been a few studies that show that there's just some women that are sensitive to that drop off in progesterone in the late luteal phase that happens before menses. And testing the level doesn't tell us that much, because regardless of what the level comes back at, the answer is still progesterone in the luteal phase. And so if it doesn't change how you are treating, then we have to question as to whether that test was useful or not. It's different where if you're testing, hormones to see why somebody may be having an issue getting pregnant, right? They've been trying for a year or something like that, then that makes sense for sure. But the study that was done showed that it wasn't the absolute levels of progesterone that indicated which women would have more severe PMS. It was just that some women were more sensitive to going from higher progesterone to lower progesterone. And so their absolute number didn't give any evidence as to whether or not they would be in that group or not. And luteal phase progesterone can make a huge difference for some women. So we definitely use that in our practice.
That is actually really interesting, but I'm curious about testing estrogen, because perimenopause women, that estrogen can really be low. So is it worth testing estrogen, and should we test on a certain day of the cycle?
Yeah, absolutely. So if you're wondering if perimenopause, or even, if you're getting close to approaching actual menopause, then that's a place where we definitely do test. We'll test FSH, estradiol, we'll just throw in LH as well, and progesterone. So we'll see where all of them are. And you can test it a few different times in the cycle. With FSH and estrogen, day 3 to 5 is the best time, and day 1 is the first day of your period. And then for progesterone, it can sometimes be helpful to test around day 19 to 21 in the luteal phase, where progesterone will be at its highest level. But that will give us some information, because what happens in perimenopause is FSH starts to increase and estrogen starts to decrease. Perimenopause can be a little bit more chaotic because your levels are going like this. And so you may be catching it here, you may be catching it here. And so sometimes we'll have to do a few, but you can also base it off of symptoms and age that the mother went through menopause. So I always ask my patients, when did your mom go through menopause, if you know that information? And then if we start to see estrogen being lower, FSH creeping up, then we're saying, okay, this looks like, it could be perimenopause.
Well, thank you so much for explaining all of those tests. But I'm curious, the average person or the common person, how often do you recommend they get blood work done? Is once a year optimal, or what is optimal?
Yeah, and I think it really depends on where you're at. So when somebody comes to see me, we test everything. We do a comprehensive blood panel. And it's not uncommon that some, maybe one or two markers come back abnormal. And in that case, we're going to test those markers depending on when we would expect them to change. So, for instance, if a 50-year-old man comes to me and his testosterone is super low, he's already tried everything lifestyle wise, we decide to put him on testosterone replacement therapy, then we're going to retest him in a few weeks, few months to make sure that that therapy is actually working and we have him at the optimal range, right? Same thing for you come in, your cholesterol, your LDL-C, ApoB is super high. We push you on a therapy to lower that, and we're going to recheck that in like 6 weeks to make sure that you're now at the optimal range. Once all of your levels are like dialed in and like everything looks good, then you can test your labs every 6 months to 1 year. So I don't really recommend more than twice a year, and some people once a year is fine. Talk to your doctor, depends on, your preference too.
Okay, so I actually had someone ask me this the other day and I wasn't sure the answer, so I'm going to ask you. They asked for their 10-year-old child, like, do we do a complete blood work panel yearly on kids? And if not kids, do I wait till they're a teenager? If not teenagers, an adult? Like, what is the answer for that?
Good question, and I'm going to plead that I don't know, because I don't treat any children here. So children are very different. I think sometimes we think children are little people, like little adults, and they're really not. And so, yeah, you would want to talk to a pediatrician, a pediatric specialist, about that. But I definitely see teens. And so once you're, an adult when it comes to body size and everything like that, then I do the same thing with them as I do with what I just said.
Okay. Well, I appreciate you taking the time, and I know we're getting close on time here, but I have one last question, and maybe you'll just have to give a brief generic answer on this, but are there other health and screening tests that you really like? Because I think I've heard you talk about like the DEXA scan. So do you like the DEXA scan and why? And are there other ones like that out there that people should look into?
Yes, love the DEXA scan. For my preventative med patients, I'm almost always talking about it because BMI, so body mass index, and your general weight is a really broad way to look at something. And it's not useless. It gives us some information, but it doesn't tell us about what's actually happening underneath the hood. So it's just telling you this is how much you weigh, and this is your weight versus your height kind of ratio. You can have a normal BMI, but have a high body fat percentage. You can have a normal BMI, but have a really low muscle mass amount in your body. You can have a normal BMI, but you can have a really high level of visceral adipose tissue. And all of those measurements are going to come on a DEXA scan. And it gives us a lot of information, much more than your just weight, about where your health stands, which is what I really care about with these patients. So huge fan. You can get them usually for we have a discount for our patients, like $55 or something. And I think it's well worth it if finances are there. The other one that I do is a VO2 max test on my patients. Some people love it. Some people don't like it that much. It's a maximal exercise test where we're really pushing the heart and lungs to assess cardiorespiratory fitness levels. And because we know from the research that having a higher level of cardiorespiratory fitness greatly reduces the risk for mortality, all-cause mortality. And so it's a good one to check out, and you can also change that. It can be changed. You can increase your VO2 max test. And then we look at grip strength with our patients too. So we test that in the office. Grip strength is a really great marker for just healthy aging and mobility. And there's some studies that show that grip strength may be more powerful as a predictor of cardiovascular mortality compared to systolic blood pressure. Now, it doesn't mean we don't test your blood pressure. It's just as important. We want to test both, but we want to assess you from different aspects to see, are there weaknesses that we could actually work on? And with grip strength, it's really a proxy for total body strength as well.
So interesting. I actually was just reading about grip strength the other night. And so, yeah, really interesting. Thank you for sharing those other tests. And those are things that people can go do. They're online. You can schedule them, through companies online and things like that. And so will you tell my listeners where they can learn more from you? And Do you still take patients today?
Yeah, absolutely. So Modern Meds, modrnmed.com. There's no E in modern. I have a ton of blogs and interviews and things on there for additional education. You can also schedule a complimentary phone consult with one of our Modern Med doctors, and I've hand selected the doctor so they practice like I do and have similar outlooks on health. And I personally do still accept patients in a concierge model for people that really want to do like a very deep dive into their health with a high touch point case. So there's a lot of access to me. We go through all the testing that we talked about today, but way more too. So if you want to geek out on that level, then I'd be happy to chat with you. And then I give away a ton of free content on Instagram. So if you want to hear more about all of these tests and other things around health and gut health and poop and all the things, then my handle is dr.mary.pardee.
Yeah, you guys go follow her on Instagram because I promise you will learn a lot. She is a wealth of knowledge, and I love the stuff that you always share on there. And so thank you so much for being here. I know you're extremely busy and running your practice plus doing the social media. So I really appreciate you taking the time to be here. And I always end my podcast with asking my guests what they have found to be the best ingredient in life. What would you say it is?
I love this one. Community. It's an easy one for me. Community and love. I think that, we can optimize everything. And if you don't have community and relationships and love, then life is not quite as fun.
I love that. I don't know if maybe one other person has said community, but that's not one that is shared often. And I agree with you. Community to me is huge. It's the relationships, the support, the love, the positive people in your life. And so I agree. Well, thank you again, Dr. Pardee, for being here. Like I said, I really appreciate you taking the time.
Thank you so much. This has been wonderful. I hope everybody learned something. And thank you for what you do. I mean, I listen to your podcast. You have such great guests on. The amount of information that you are sending to the world is so necessary and really appreciated, and can't wait to keep listening.
Thank you so much for listening. Remember to subscribe to the Just Ingredients podcast to learn more about your health and good ingredients to life. Plus, get daily tips at just.ingredients on Instagram.